Now, the thing about it is that pressure gets too high, you get so much fluid or blood in there, it's nowhere to go. So what you end up is having herniation that happens. Herniation of the brain, tentorial herniation, as they call it. Those people die because what is at the base of your brain? The respiratory centers. So that's the thing that you see that's different. When you see ICP in a patient, for whatever reason, some of the things that kind of give it away is that you're going to have this person with a widening pulse pressure, meaning the systolic and the diastolic pressure have far away from each other. So this is a person who has a systolic blood pressure of 200, diastolic blood pressure of 60. They have bradycardia with a bounding pulse. It's almost like you can feel the pulse going off the patient. I mean, you put your fingers there and you feel it really strong. And then they have irregular respirations. Those are things that you see when you have herniation going on. That's it. It's the point of no return when you're talking about that happening in your patients. But it can happen. You want to prevent that from happening, but that's what generally happens when you have patients that have aneurysms. You code them, because I have done it in the past. And sometimes very bad codes, kind of thing. And it's not because every code is bad, but sometimes there are people who you never thought this is what's going on. And they're in the hospital, you're seeing them for something else. And then you hear them, then sometimes they let out a scream that is like nothing you ever heard before. You go down and code the patient, and you're coding them on the floor because they fell out on the floor, kind of thing. That's happened to me twice. The patient had aneurysm. So you get them back breathing, they go to the unit, but they're vegetables at that point. Unfortunate, but it's true. And both people it happened to were young people, 29 years old, one girl. And it's just, she told us that morning, she said, oh, I have a headache. She didn't say the worst headache in my life. She just said she had a really bad headache. And then probably about 30 minutes later, you heard her yell, and she was on the floor. And we coded her for about 35 minutes. But you just do what you need to do. But unfortunately, that's something, if you don't catch it before it ruptures, you may not have a good outcome. And we actually had a nurse that was one of our instructors that this happened to. She, over a Thanksgiving break, because they called me, I was out of town, and they said that Marilyn was in the hospital. I'm like, what is she in the hospital for? But she actually started to have the bleed started slowly. So she actually had some changes, and when somebody came to see her, they said she was talking crazy. It didn't make sense what she was saying to people. And so thank goodness somebody did go see her and ended up taking her to the hospital. She was at Florida Hospital. They airlifted her to Tampa General so she could have a special kind of coiling done. She ended up with a ventricular shunt, all this kind of, she ended up with a lot of problems after the fact. And now she walks with a cane. But her thing is she could remember everything about medicine because she was a nurse practitioner. If you asked her anything about medicine, she could tell you. If she was in front of class, she would teach the same thing over and over again because she couldn't remember that she taught it. So that was the weirdest thing. She finally said, I can't do this anymore. I mean, that was her thing to leave, but that was it. If you asked her anything medical, she was like an encyclopedia about medicine. But if you asked her to teach something in a class, she taught it because it's content she knows. But then she would wait, if it was 10 minutes later, she'd start talking about the same thing again. So students were having a fit, of course, kind of thing. Which is true, because you got to get past, you can't talk about the same thing all the time. You got to get to the rest of the content. But she ended up retiring, but now she walks with a cane. She ended up with a shunt because she was still having pressure inside her head, even after she had 2 coils done. So it's just, every person is different. And as far as what they do. And that's one of those things, your body compensates and does stuff. Because if I called her now, she'd still be able to tell me stuff. But there's stuff all over her house to remind her where she is, kind of thing. So you have all kinds of things that can end up happening to your patient. The head is truly the body is a magnificent thing. It can go through a lot, but it can also be problematic. So that's the issues that you have. It's a miraculous thing, but things can happen to your patient. So aneurysms are just that. Usually complaint that you're going to have for a person is the worst headache I ever had in my life. The vast majority of patients are asymptomatic. That's usually the thing they complain about when you talk to them. And then when they separate it out into intracranial bleeding, I'm like, why? kind of thing, because the end result is the same. But just a little bit about hematomas and strokes, because we talked about strokes in EPT. All right, so hemorrhagic strokes are always things that are evolving, because you got to get that blood to stop in a patient. Okay, so blood is bleeding, it's tissue, it's being destroyed because you have pressure inside the head. That's why patients who have hemorrhagic strokes die more than patients who have thrombic strokes. Both of them can end up dying, but especially when you talk about hemorrhagic stroke, because it continues to extend what's going on with your patient. But the thing I want you to kind of think about when you're looking at this, think about the hematomas, because there's two couple things we kind of look at with that. Subdural hematomas and epidural hematomas. Epidural hematomas are happening on top of the brain, or so they're between the brain and tissue that happens with your patient. That space is very small, so patients that have epidural hematomas can be symptomatic quickly. Okay, that's the one kind of thing that gives it away when you think about an epidural hematoma. Usually you have a patient who may have a short term or a short period of time where they're unconscious. They come back, you know, they're wide awake now, and then they go somnolent. That's ominous, because that shouldn't happen, kind of thing. So period of lucidity followed by a patient being out, and it usually happens after some type of head injury, because remember, that's a shearing type injury. So you have something that happened when a person was hit, or they may have, you know, been come in contact with a static thing, but they were moving. Okay, because some of the famous people who died from epidural hematomas, Natasha Richardson, who was married to Liam Neeson, skiing down the slope, hit a tree. Sonny Bono, skiing down the slope, hit a tree. Now, he never regained consciousness. Natasha Richardson said, oh my goodness, my head hurts. They go let her lay down and sleep. They find her almost dead. And then she ends up dying from it, because that's the thing. Patients are okay for a period of time, so everybody thinks everything is good, we're done, no problem. But remember, bleeding is happening, and that's what happened to her. She ended up dying from, she had herniation by the time they actually took her to the hospital. So epidural hematomas bleed a lot, but the thing that makes them different, or how you pick them out, period of lucidity, and then the patient becomes unconscious, unresponsive. Subdural hematomas, because it is in the subdural area, can either be that same way, but most subdural hematomas bleed slowly. So you may not see symptoms for a period of time in these patients. Some patients, you don't see them at all. We just come in and they do an x-ray on somebody and find out they have subdural hematomas. You go like, when did you fall? They don't even remember. The worst ones are drunks. They fall off the bar stools, kind of thing. And I know this sounds like I'm picking at folks, but in truth, sometimes they come in the hospital, they'll have 5, 6 hematomas. And you ask them, when did you fall? And they don't even remember, because guess what? They're drunk. They don't think about it. You know, they're the ones that fall over and don't think about nothing. Don't try to save nothing. They have stuff everywhere. And then they end up coming to the hospital and you say, well, you have 6 of them in there. And that's because they've been falling all the time. Some of that could be because the hematoma is now taking up more space. Because remember, blood is there. Blood is one of those things that, you know, you can decrease or increase based on what's going on with the patient. But if you keep increasing it, you're going to have symptoms in the patient. So subdural hematomas can present like an epidural, meaning fast, but a lot of them bleed slowly. So you can have patients who are totally asymptomatic when they're talking about complaining about stuff, all the way up to the person that's totally unresponsive when you're talking about hematomas. But we still have to, that's something that you can evacuate. You know, they can go out and suck them out, suck the clots out for the patient. And that's sometimes what ends up happening with them. Last on the list is neurogenic shock. So this is a shock state that happens with neurologic problems. You know how we've kind of done the shock with each one of them as they go along. So spinal cord injury patient, this can happen with. Head injury patient, this can happen with. All right. Now it's a little different from the other types of shock. Yes, O2 will always be something you give the patient. Fluid sparingly for this group. Mainly because in neurogenic shock, there is vasodilatation within the vascular system. Because you know how most of the time when things are, we're thinking about, I need to give them volume to raise the blood pressure. If you gave this person volume, they would drown. Okay, because vasodilatation means the pathways are open, blood pressure is low. Even if I give them fluid, blood pressure is going to stay low. That's because it's not moving it along. Okay, because vasodilatation means I have no tonicity. Afterload is decreased in the vascular system, therefore I can't raise the blood pressure that way. To treat this person, I actually need to treat the underlying cause, but also I'm going to need pressors. So that's the person that's going to go on dopamine, because I need to raise your blood pressure. That's how I need to do it. IV fluids are not going to do it. I'm going to have to give you something that causes vasoconstriction. So those are the things I'm going to give to this patient to raise the blood pressure. Doesn't happen a lot, thank goodness, but it can happen with any neurologic injury that a patient has. So when you're talking about spinal cord injury, when you're talking about head injuries, that's when neurogenic shock can happen. It is reversible, but you got to catch it. That's the thing. Once you start seeing these things happen, you see this widening pulse pressure that's happening in the patient. Their blood pressure doesn't, the thing that you see with them is that you're thinking, oh, this person is having this problem going on, their blood pressure, or you see them shocking because you see the signs of symptoms, the cool, clean the skin, all that stuff is happening. And you're thinking the heart rate should be really high. That doesn't happen with a patient who has neurogenic shock. And their blood pressure does not respond to the fluid bolus, because a lot of times that's what doctors will do, give them a fluid bolus, see if their blood pressure goes up, because it should. If you increase vascular volume, blood pressure should go up. If it's not responding, then you look for this could be neurogenic in nature. What's the other one that doesn't respond to fluid bolus? Because you saw a video on it.
Subsection.
Because that's one of the things that tells you when you got a person that you think they have other stuff wrong with them, because you're thinking about this person has an infection or they have a temp, because that goes with septic shock. But one of the things that tells you they have past sepsis and now they're in septic shock is that you give the person a fluid bolus and their blood pressure doesn't respond. That's one of the things you kind of look for. That's what's going on. So that is the overview. I will go home this weekend or in the next few days, because I got a doctor's appointment tomorrow, and do voiceovers for the content, because the PowerPoints are on the class. Major things you got to look at. Make sure you look at the assessment piece about what goes on with your patient for Glasgow Coma Scale, doing your assessment on a patient who has neurologic problems. Make sure you know ICP and head injury kind of thing. It's the ICP, care of the patient, when you talk about head injury, not so much the classifications. So don't think about contusions, concussions, that kind of thing. Think about what you're doing because a person has a head injury. That means I'm checking neurologic status, looking at pupil response. I'm looking to see if they're nauseated, or if they just have projectile vomiting, because those things tell me that ICP may be happening there with the patient. Spinal cord injury, we kind of talked about. Look at the level of injury that your patient is having, the things that we do for the immediate period after spinal cord injury, not the long-term rehab phase. You're just looking at what happens with the patient during the acute phase and what happens with your injury. Think about autonomic dysreflexia, because that's a big complication. Maintaining your airway, especially when you talk about cervical injury with your patients. This person, I forgot one other thing about that one, because there's a shock that goes with spinal cord injury called spinal shock. Okay. When you have a patient who has any type of spinal cord injury, initially after your injury, you're going to have a patient who has what we call flaccid paralysis, totally. And when I say flaccid paralysis, that also means that deep tendon reflexes don't exist. Because reflexes are things that your body has regardless. Those are things that are inborn in you that say you need to try to save something. When a patient has spinal shock, you have absence of movement, absence of deep tendon reflexes. When spinal shock is resolving, deep tendon reflex return. You still may not have movement, but DTRs return, as we call them, deep tendon reflexes return. So if I actually hit you right after your injury with a reflex hammer and you don't move, I know you're in spinal shock. If I hit you and you start to have a twitch, because that's part of the deep tendon reflex, I know that spinal shock is resolved. We look at that because sometimes you can't tell how badly a patient is injured until after that shock is resolved, especially when you talk about the partial ones. Okay, so you have people that might have something that comes back after that point, so you kind of look at what's going on with the patient. Think about the complication autonomic dysreflexia, how we manage it. Think about what you're looking at if a patient has a certain level of injury. C's are airway, thoracics are breathing. So you think about pneumonias, lower when you talk about patients who have bowel and bladder problems. With our vascular things, look at aneurysm, and then look at your hematomas. Okay, because they have stroke up there. It's still a bleeding process, because as you're talking about hemorrhagic stroke, it's all about bleeding into the brain. That's something that's not controlled. Think about your people at risk and who's going to extend the injury. Anybody who has hypertension, you worry about them even more, because that's all that end organ damage not being perfused. I got to worry about this person having an injury that is more diffuse, more stuff going on with the patient. And then for our endocrine stuff, we kind of went over, like to say, you guys actually had thyroid toxicosis, but think about the effect of thyroid hormone on tissue. So everything's speeding up. One of the few times we start medication high, antithyroid drugs are started at high dosage, because then you're going to lower them based on the patient response. So that will be something that changes over time. Think about that person who might have a thyroidectomy because this is going on. What do you do for the patient post-thyroidectomy? Look for bleeding, maintaining airway, and you cannot get a tube in that person. That person needs a trach kit at the bedside. Also, you may have to give them calcium gluconate because parathyroids were taken out when they had surgery. And think about those signs and symptoms that go with hypocalcemia, because that's something that is a direct response to that, the parathyroids being removed. Then we had our pheochromocytoma, crazy tumor that happens on the adrenals. Increased catecholamine, so epinephrine and norepinephrine release, what you see associated with that. High blood pressure, as you think about what's going on with this patient, is intermittent. That's the kind of thing that gives it away. Person's not hypertensive all the time. They just have it sometimes. They get tremors sometimes, nervousness, that kind of stuff associated with it. But that's what happens when your catecholamines are released. Think about test day and how you feel. Think about it pronounced in a patient, because now they have this hormone going on all the time. So that's what essentially is happening with that. If we can take the tumor out, it usually solves the problem for most people. About 30% of people still need antihypertensive meds. They don't get the tremors and that kind of stuff, but they still have hypertension. Then we had our pancreas stuff. So hypoglycemia, the only one with low blood sugar. How do you manage that patient who has low blood sugar? For testing purposes, that's blood glucose less than 70. Then we had our patients who, all the other ones are things with high blood sugars. That's why I put high blood glucose. So we have patients who have diabetic ketoacidosis, which happens in type 1, HHNS, type 2, and then we had morning hyperglycemia. Samorgia was the crazy one. So what happens between 2 and 4? Patient is hypoglycemic. So that's a counter-regulatory thing that's happening with the patient. Okay. And then Dawn phenomenon between 2 and 4 is high. So just think about it. It's high, it keeps going higher. Okay. Like the sun is rising. All right. So make sure you send me any questions that you may have, but I will go over and do voiceover PowerPoint.
You don't be responding.
Nobody sent me a question on. Who sent me a question on email?
It's hard. No, you cannot make me look bad.
Did everybody get a handout?
Yes.
All right.
What she got.
I'll get one for Diane.
But this has stuff for some of the endocrine, and it has the neuro stuff about testing and looking for ICP in your patients. Also has some testing that we do for D and DI, and then some of the things that you do for managing your patients. So hopefully it will help.
Are you going to
Ms. Henderson,
Yes,
when's the test?
Tuesday.
Tuesday.
Yeah, I'm serious. It's not time for that. Come on. Get it away. I almost died.
Like five of them